You're welcome. Okay. Hi, everyone. Thank you, Danielle, for that wonderful introduction and for inviting me to come out here and participate in this meeting and opportunity to meet you all. A number of you I receive emails from, calendar invitations from. We've been in communication, so it's nice to come out here and finally be able to put faces to names. I'm really looking forward to hearing from you all what some of your experiences have been, some of the issues and challenges that you found you've run up against, so that I can sort of take that information back to DC and we can sort of work together to figure out how best we can address some of the engagement-related challenges and issues that you face when you do your research or participate in research. So in terms of what we'll cover today, I'll just give a little bit of background and overview of PCORI. I'll also provide some information about resources, tools, activities that we've created and developed to facilitate and support patient engagement in research. And then also sort of discuss, I'd like to have an active discussion about some of the gaps that exist out there so that we can determine how best to address those moving forward. So just to provide a brief overview, PCORI is an independent research institute that was authorized by Congress in 2010, and it's governed by a 21-member board that represents the entire healthcare community. Our mission is to help people make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based information. So essentially, we aim to generate evidence that is from research that's guided by input from patients, clinicians, and all relevant stakeholders. So we fund PCORI, which is a relatively new form of CER that considers patients' needs and preferences and the outcomes that matter most or is most important to them. I'm sorry, my notes are throwing me off a little bit up here. In order for research to get funded at PCORI, it has to satisfy these 5 criteria. And you'll notice the 2 of the 5 criteria focus on patient-centeredness and patient and stakeholder engagement. And that's really what sets our organization apart from other institutions like the NIH and other funding agencies. Some people, when they describe PCORI and PCORI, they use the words innovative and disruptive. Innovative in the sense that we are approaching research and the conduct of research with a new approach, and disruptive in the sense that we're challenging a lot of historical norms in terms of the conduct of research. But no challenge is too big for PCORI, if you will. So now I want to switch gears a little bit and talk about engagement and why it is so important to engage patients and stakeholders in research. There are a number of different reasons. This is sort of the million-dollar question that we get every time. Why engage? Why is it important? Does it really make a difference? And in terms of our response, engagement really influences research to be patient-centered, relevant, and useful, to establish trust and a sense of legitimacy in research findings, and to encourage the successful uptake and use of research results. So if our end goal is to essentially generate evidence from research that is going to be used by patients for making informed decisions about their care, it almost seems like it's common sense, if you will, to engage them in the actual conduct of that research, such that the evidence that you generate is more relevant and useful for them, for their decision making. I want to show a short video that really discusses, from the patient's perspective, why it's important for patients to be engaged in research. This is a video you'll hear from 3 women who are patient partners on projects in our asthma portfolio. And they discuss sort of the impact that being engaged in research has had on them and their lives. So how do I get this teed up?
intimidated because at first it took a minute to really figure out what my role was going to be. And it was like, okay, so what am I going to do? In the other studies that I was involved in, I was more the person being helped, whereas in this study, I feel like I'm on the other side along with the researchers of helping and find out what we can do to get the information from the patients. So I know one of the major things that we helped with was helping them understand more about the apprehension that the patients will feel. My mom is one of those kind of people, if you come in her house with an iPad, she's going to send you back outside. My mom, by the way, is an asthma patient, and she totally mismanages her asthma. She doesn't listen to anybody. And, if you're supposed to be helping her, a medical person, she doesn't want you with anything that looks remotely like a computer. It's the funniest thing to me. And it's like, Mom, I work with computers. I don't want them studying me and singing, But anyway, long story short, I brought up that kind of stuff, and they were like, oh, okay, we didn't think about that. So it turned out that I had a lot to offer, so I was really grateful for that. Anything you bring, no matter how small it may seem, anything that you say, any ideas that you have will be valued. And, a lot of things that I didn't see or think that would be that important turned out it was, something that was really good.
I think I play a valuable role, and I don't think I really realized how much until we went to a conference and I participated in one of our presentations about the patient, the provider, and the researcher. And I don't know, it just seemed to be a hit with everybody that was there. It's dealing with shared decision making, and we try to get the patients to participate more within their treatment. A lot of times the patient goes in, they tell the doctor what's been going on with them. The doctor tells them, okay, well, this is what you need to do. But then the patient never told the doctor how the last time they took the medicine, they had some adverse reaction, or maybe the medicine cost too much, so they had to decide between buying the medicine and buying something else. So the doctors are making decisions based on an incomplete amount of knowledge, and it's not always the best decision for the patient. So we want the patients and the doctors to work together. I feel like when I'm a part of the research team, I represent other patients or other families who are dealing with asthma, and in many cases, patient voices aren't really heard or they may not be acknowledged. So I feel like I represent them and I advocate for them. That made me feel proud to be a part of that research team, and they were happy to have me.
I knew this was going to be my opportunity to really learn about asthma in a way that I really wanted to learn about it. That's what made me want to do the study. Every time we do something, I'm learning more and more about asthma and the study and what we're trying to do. We're bringing experience from our place as a mother and also as the breadwinner and the main one doing preventive measures for our children. If it was just us and our group, people would hear us, but would something be done about it? But the parents and the doctors, the coaches, everybody could pull together, take our concerns as parents, and bring up some type of action that could help a little bit. We kind of became kind of like a family of people with the same common interests. And our group is so diverse, like they're real, and that's very rare. If it's something bothering me, I can talk to them. They're not too big and too above to talk to little old me. Then to hear the professionals say we inspire them, it kind of makes you feel good inside and make you feel like, we're all in this together.
Be open, be honest. You don't have to water it down. Whatever it is you have to tell in your story, don't be afraid to tell it.
Know that what you have is valuable. And what you have and what your experiences are valuable.
You're going to come out more informed and with more hope than before you went in.
Okay. Let me get teed back up here. So I really like that video, partly because the message, if you will, that I get from it is empowerment. by having a seat at the table, by providing contributions and for their input to actually be really taken seriously and woven into improving the study really is what makes a difference for patients. And feeling empowered then can potentially translate into how they manage their own conditions, how they manage the conditions of their children or their parents, as you can see from one of the women that was in the video. So that's sort of when we're pitching the message or preaching the gospel, if you will, of patient engagement and research, it's sort of twofold. It's not just about ensuring that your research is relevant and useful and meaningful, but it's also about providing patients with the opportunity to feel empowered and to really take charge of their conditions and their health. So oftentimes we get questions, you know, we talk a mean game about engagement, if you will, but what exactly does that look like? What exactly do you mean when you say meaningful engagement? And I'm sharing this slide. It's sort of our virtuous cycle of engagement, if you will, and it really just sort of highlights that there is a role for patients to be meaningfully engaged in the conduct of research in all the different phases, from topic selection and research prioritization all the way to evaluation. And we're going to sort of come back to this in upcoming slides in terms of getting down to some of the nitty-gritty in terms of activities that patients actually participated in during each of the phases. And then going back to the number one question we have as well in terms of what we mean by engagement, what exactly is meaningful? What is meaningful involvement? How you make engagement meaningful, if you will? And I think that it really sort of boils down to your approach. It's twofold, if you will, leading from within, and to me that means sort of checking a lot of those internal biases that you have. My training and my background is what makes my input more superior to the patient partners that are sitting at the table with me, or because of their lack of training or lack of educational background, that makes their input a little bit more inferior. And then on the other hand of that, the other part of it is leading together. And this is the piece that sort of addresses the true partnerships. It's one thing to have a patient that has a seat at the table and they're an engaged research partner, but what happens when we start to find that they really don't truly have a voice in terms of the authority to make decisions with respect to the project? So this is where things like shared decision-making and your governance structure really sort of is important and critical and comes into play. Ensuring that your patient partners who are a part of your project have the knowledge, have the tools, they really feel equipped to be able to provide meaningful input and make decisions with respect to the conduct of the study. So if we have those pieces, it almost seems like the rest comes, I don't want to say easy, but it comes a little bit more naturally, if you will. And I think it's also important to emphasize that, as Danielle alluded to earlier, engagement is not one size fits all. There is not one specific way to do it. Every community is different. Every health condition is different. So what works for the diabetes community may not necessarily be the same as the asthma community, may not necessarily be the same as the breast cancer community. It's all sort of, going to be different. It takes different shapes and sizes. And at PCORI, our role really is to look to the field and to gather as much information and repackage that and share all the different types of examples and initiatives that are going on the field. So in terms of building infrastructure for patient engagement, I want to take some time to talk about some of the activities and initiatives that we have going on. One of the main tools that we use to facilitate engagement is the engagement rubric, which some of you may already be familiar with. It's essentially the framework by which PCORI views engagement, if you will. And the way that it was developed, we looked again to the field to see what were those activities, what were those promising practices that were happening. We brought them all together, packaged them in sort of identified themes, and that's sort of how the engagement rubric was built. And there are 3 different phases: planning the study, conducting the study, disseminating the results. I will say that there is a lot of discussion in-house at PCORI about updating and revising our engagement rubric. We hear from the field, and as also internally, one of the key things that's missing is the pre-engagement piece. So what are some of those practices, activities, what goes into the pre-engagement piece that we're not fully addressing with our engagement rubric? And so we're gathering information from our projects like our engagement awards and our pipeline to proposal awards to sort of fill in the missing holes and build in a new pre-engagement component to our rubric. In addition to that, we've also heard from the field that the engagement rubric it's more tailored to the applicant, if you will. And the information and examples and content that's provided in there is not sort of widely applicable. And so we're also sort of updating and working on updating and revising the engagement rubric so that it sort of speaks to all different audiences and anyone can use it, not just someone who's applying for a PCORI award. So these are some of the types of activities, if you will, that happens during each of the phases of the research project with respect to the engagement rubric, and some of the ways that patients and stakeholders play a role in terms of planning the study, obviously identifying the research question, identifying the outcomes of interest, and helping to develop study materials. In terms of the conduct of the study, assisting with recruitment and retention, revising informed consent materials, making decisions about study adjustments. You heard in the video, the short video that we played, the woman that was saying with her mom when researchers came to the door with iPad, that did not fly with her, at all. And these are little sort of tidbits and examples that researchers hear when they engage patient partners and then now turn around and sort of revise their study protocol so that it is more tailored and speaks to their needs. And then, of course, dissemination of study results. Patients play a role in terms of co-presenting with researchers as well as co-authoring manuscripts as well, and also helping the research team think through what are the appropriate avenues to disseminate some of the research findings. Where can we reach patients and have sort of the most impact? So other engagement tools that we have developed is the compensation framework, and this one is geared more towards applicants as well, but they were essentially looking for guidance on how do we know what's the right amount to compensate a patient partner. And in our framework, we don't necessarily, again, because it's not one size fits all, engagement is not one size fits all, we don't necessarily say this is the exact amount that a patient partner should be compensated for this amount of time versus that amount of time. But instead, we encourage the applicants and the researchers to think through compensation from the standpoint of some of the engagement principles, so the trust and the transparency. If you're compensating a patient partner versus a stakeholder partner, is that being done on the same level? Are they getting the same amount? Are they not getting the same amount? And really sort of thinking through and building that out. In terms of other engagement tools, we have our personnel. So as Danielle had mentioned, I'm an engagement officer, and this is sort of a new concept or a new position that PCORI created, where essentially we are tasked with serving as a bridge between engagement and science. So we consult with PIs, with program officers and various folks in the science team to really help them troubleshoot and navigate some of the engagement challenges that they face. I've been at PCORI for a couple of months now, 4 or 5 months now, and the kinds of questions and issues and stories that the EOs get on a regular basis, sometimes we really don't even think of them ourselves. They seem so small and menial, if you will, but they have a really strong and significant impact on the way that these studies are conducted and whether or not they'll be successful. So in addition to helping to troubleshoot and navigate some of the engagement challenges, we're also tasked with gathering those promising practices from the field and using both the promising practices and the challenges that we hear about to develop tools, resources, toolkits, and all sorts of supportive resources for our science team as well as for the researchers at large. In addition to that, we also have our PEEP advisory panel, our patient engagement advisory panel. They've been really instrumental in terms of helping us think through and vet, if you will, some of our strategic initiatives, providing feedback on our evaluation framework and things along those lines. These are sort of the real experts, quote unquote, if you will, with respect to the patient engagement space, and they provide us with a great deal of support with how to really, help and move this field forward. And in addition to that, we also have programmatic funding, like the Eugene Washington Engagement Awards and the Pipeline to Proposal Awards. And these two programmatic awards, I really feel as though they support the capacity building and the infrastructure for engagement. So bringing all of the relevant stakeholders together to have some of the discussions that we're going to be having over these next 2 days, to bring in those individuals who are non-usual suspects, quote unquote, in the research process, and really educating and equipping them with the information that they need to understand about PCORI to really be able to contribute and have a meaningful contribution as a research partner. The Pipeline to Proposal Award, again, this is really focused on the capacity building piece. So when I describe and talk about this award, I like to think that this is the award that covers all the pre-engagement activities. How do you convene all of the stakeholders to come together? How do you determine who's going to be on your advisory panel versus who won't be on your advisory panel? How do you come to identify your CER research question and prioritize that with all of the different diverse stakeholders sitting around the table working together? And this particular award really supports all of that infrastructure building and capacity building that's necessary to have a successful PCORI project. So other engagement tools that are coming down the pipeline, if you will, one of the documents is a milestone guidance document, and this one is a little bit more tailored to the applicants. We see in our milestones that comes through on our proposals, sometimes the ones that are related to engagement are very vague. It's something that's as simple as stakeholder advisory panel meeting. Okay, so what's the purpose of that meeting? Will you be able to share the minutes from those meetings? Getting a little bit more detail. But again, researchers, they weren't sure. They didn't know what was supposed to go in those fields. And the POs we found and our science team weren't able also to provide them with adequate guidance. So we developed the milestone guidance document. And right now, it's in the process of being woven into the next funding cycle. In addition to that, we also have an engagement toolkit that we're developing, and our PEEP advisory panel has really, really been instrumental in helping us sort of fine-tune this toolkit that'll be available both for applicants as well as just the general research audience at large that has a vested interest in PCORI, and it'll include a lot of the documents that I'd already discussed, like the budgeting documents and compensation framework, as well as other tools and resources. And then lastly, we have an engagement webinar series, as well as online trainings that we're developing. We're in the process of developing an online training program, an online and in-person training program for our Pipeline to Proposal awardees, because we found that this particular audience, majority of them are not researchers, and they don't have a strong research background, and they're convening and coming together and forming partnerships with researchers. So they sort of needed that Research 101 training in terms of determining what makes a research question, a CER research question, and reviewing things like the PCOTS framework. They needed that guidance, they needed that sort of support. And in terms of our engagement webinar series, this is each different topic for the series, it covers different issues that we've encountered that researchers have brought to our attention. The first webinar is going to actually be held this Thursday, and the topic is governance structures. So how do you know how many patients is the right amount of patients that should be on your governance structure, that should be in your advisory committee? How many committees are the right number of committees? Is it okay to have a patient committee and a stakeholder committee? Is it okay to combine them? Who should be on them? Who shouldn't be on them? And so what we're doing is we've highlighted some of our projects in our portfolio that seem to have gotten it, if you will. And they're really going to be the ones that are driving the webinar and teaching all of the participants, researchers, patient partners, et cetera, what approach they took, how they took that approach, and then providing sort of concrete guidance for the audience. So I say that to say, despite the fact that we've developed various resources and tools, we still hear from the field that we need more. Engagement is important, but engagement is hard. There's not a lot of evidence in terms of best practices and impact. It's too expensive. It's too much time. How do you sustain this? You know, a lot of the questions that we receive from the field are, do we really have to engage patients in every phase of the research project, of every phase of the research process? Is one phase more effective than the other? Again, what does engagement look like? What are the appropriate governance structures? These are all some of the questions that we constantly come up against and we face, and we look to the field to sort of help and answer those questions. So what I'd like to have a discussion with you all today is to help us identify what are some of these what are some of the things that are missing from this list that I have? What are some of the things that you've encountered in conducting research or participating in research with respect to engagement that's missing, so that I can sort of take that information back in-house to DC, and we can figure out what are the best approaches to developing newer resources, tools, and any sort of support, essentially, to support your research. So I'm going to end with this quote. I'm not sure how many people in the room are familiar with the book, The Immortal Life of Henrietta Lacks. So I recently read this book. I started reading it a couple months ago. It's actually sort of right around the time I started at PCORI. It was not intentional. And I was really sort of struck as I was reading it, because I started to see that there were so many similarities and parallels, if you will, to what happened during Henrietta's era versus now. For those of you who are not familiar with the story, Henrietta was an African-American woman from Baltimore. She had cancer, cervical cancer. And her clinician took a little piece of the tumor that was growing on her cervix, and sent it off to be studied for research. And her cells actually were instrumental in the development of all sorts of medicines, treatments, vaccines, devices, et cetera. And the list goes on. And she had zero knowledge of this. Her family had zero knowledge of this. And her cells were essentially taken without her consent. And in reading this quote, like many doctors of his era, Talend often used patients from the public wards for research, usually without their knowledge. Many scientists believe that since patients were treated for free in the public wards, it was fair to use them as research subjects as a form of payment. And so as I was reading the book, what struck me was that the level of pushback, if you will, from the researchers and clinicians when they were sort of questioned about their approach to conducting research. It was almost like, why should we ask a patient's consent before we take something that belongs to them? This is all to advance science. It's all for the greater good. And so in that time, patients they didn't have a name, they didn't have a voice. They were essentially just a combination of letters and numbers. And now we fast forward to our time, where patients do have a voice. They are seated at the table, if you will, but we still have a very long way to go, and that there are some folks that are still very skeptical of this new approach to research. why should we really engage patients in the conduct of research? Do they have the wherewithal and the know-how to really make a contribution? And so I wanted to share that with you all to sort of leave the lasting message of, yes, we've come a long way where patients are no longer just numbers and subjects, and they're actually seated at the table, but we still have a long way to go. And I applaud you all for your efforts in working in this space, and I really sort of task you and charge you with continuing to help PCORI advance PCOR and the science of patient engagement and research, because it's really the way forward, and it's in my opinion, the most realistic, honest, and smartest approaches to conducting research. Thank you.
We have time now for questions for Chinenye, and as she charged the group too to hear back from what was missing from her list. Do you want to reverse back to the slide that gave your list? So, yep, that's it. That's it. So does anybody have any early, yeah, and Sarah, thank you, Sarah's waving to remind me that if you have a hand up, which Nancy does in the back, perfect, what's missing?
Terminology. You talked about patients, and then you talked about advocates, and and stakeholders. How do you differentiate between all of those?
That's a great question. Patients essentially are individuals with lived experiences, if you will. Advocates are individuals who support or represent patients that have those lived experiences. And stakeholders are essentially anyone who has a stake in the outcome of the research findings. So it can be a pharmacist, it can be a clinician. If the research is studying something that is going to somehow impact their work and the way that they deliver care, they're considered a stakeholder. And every individual should be involved in the discussion in terms of determining what the research question is and what approach to take to answering that question.
This goes along to the sustaining engagement, but how to keep people still engaged with between funding cycles. Mm-hmm. So we have a pipeline proposal, mm-hmm. and so between tier 2 and tier 3, there's been a lag of funding. So how to keep it going has been a challenge when we figured it out, but it's been a challenge.
Some of the things that we see done, in particular with our engagement awards, is in their proposals, they build in sort of post-award activities, things like small workshops, webinars, teleconferences, just to sort of keep the conversation going, keep the momentum going. We had an award at UMB, while I was at UMB. It was an engagement award where we trained rare disease patient advocates on the fundamentals of PCOR. And in that 2-day workshop that we had, there was so much buzz and excitement and energy and passion in the room, and we really wanted to make sure that we didn't lose that. And so we built in sort of post-webinar activities where we charged the group at the conclusion of the training, as well as a couple weeks after, what are some of the topics that we should be discussing in a conference call or a webinar. And things like writing the research question came up. Things like navigating the PCORI website came up. Things like what is a patient-reported outcome versus a patient-centered outcome came up. And so we had a whole host of post-training activities, and the group really remained engaged. Some of them went on to submit their own engagement awards and were awarded based on all the information that they learned at the training. Some of them went on to submit pipeline to proposal awards and were awarded. So I think building in your actual proposal some of those post activities to keep that excitement going and keep those activities going is key.
Thank you.
Mm-hmm.
Thank you so much for your presentation. This is a conversation that Danielle and I have had a lot, which is how do you evaluate engagement within your own project? and I've asked this question before in different conferences, wondering where PCORI now is landing on how best to evaluate and then learn from that evaluation to change how you engage stakeholders and patients.
That is a really, really great question. And this was actually an activity that we had during our last PEEP advisory panel meeting, where we put some of our evaluation questions and our framework in front of our advisory panel and asked for their feedback in terms of, are we asking the right questions? Are we capturing all of the necessary elements that we should? And some of the things that came up from them that we now have to figure out how to sort of weave in and address is how to accurately and adequately capture influence of engagement. So how does what we're doing influence other aspects of the healthcare system, if you will? We see now more patient-centered and patient-focused talks with respect to quality measurement and patient-focused drug development. So there's a little bit more, there's a trickle effect or a spreading effect, if you will. Another space where we're starting to see it more is in the scholarly journals. For example, the BMJ has a new patient peer review aspect, and they cited, PCORI as one of the influences for generating and creating that. Another thing that has come up, that came up with our advisory panel and that has come up amongst discussions that we're still trying to get a good handle on is measuring trust. How do we measure trust? And there are some scales that are out there that exist with respect to measuring trust amongst our patient partners that we engage and determining how does that have an impact, if you will, on their level of engagement, on whether they remain involved and engaged in projects and things along those lines.
Thank you. I wonder, why did you use a cartoon instead of the real picture?
To be honest, I do not have the answer to that question. I did not develop or was involved in the development of that video. We do have a number of videos that do actually use patients' faces and their likeness. I'm not really sure why the Asthma Network chose that approach. I'm happy to find out and circle back with Danielle to share the answer with you. But I really just like the video because of the message that came from the three women and sort of the consistency in themes amongst the three of them.
Yeah, and a cartoon sends a really different message than a real person.
Interesting.
And that's evidence-based too. I just want to echo that that's evidence-based. There are a lot of people who have shown different videos.
Mm-hmm.
People relate more to videos. What I can say in the community that we work with, though, is that I'm sorry. So I was saying that there's a lot of evidence that people really do relate more to actual people than to cartoons. I think part of the reason we've gotten into these cartoons is because if I see someone who doesn't look like me, then that could make me even further away, where a cartoon doesn't look like any of us. But I agree with you. You're kind of taking away the humanity of individuals so as not to do that. And one of the things that PCORI did a while ago is they came up with this picture that was kind of what a person would look like if you took 100 people and you merged that. I don't know if you've seen that in your time at PCORI, but they have this wonderful picture in which they show how you can kind of create a person who represents many of us. That's kind of an interesting commentary. But I think this idea of visuals and how we represent the patient story is something that PCORI, should really pay more attention to, especially in your dissemination part.
It's a subtle put down.
Mm-hmm.
I wanted to see if you have, one of the things I struggle with in the field I work in is ensuring that the patient voice is representative of the patients experiencing the disease. I am a nephrologist. I work with people on dialysis, where there's substantial burden of disease and treatment. And the patients that step forward are more easy to engage are the ones that have had a kidney transplant, the people that are more educated.
Yeah.
And I struggle with the more vulnerable patient populations, the less educated, the minority populations, people that eventually die and don't live or are healthy enough to lend their voice to what I would think are the group of people for which changing patient-reported outcomes, for example, would be the most meaningful.
Yeah.
So I imagine heart failure is the same way, or people that die with cancers that don't have a long life expectancy. Do you have experience to share or ideas and how to overcome that barrier?
Well, that's definitely something that has come up often, especially in our addressing disparities portfolio as well as in our CER portfolio. And I mean, the best response that I can give at this point and that we've sort of tried to use at PCORI is just the emphasis of having a diverse group of stakeholders on your advisory panels such that you are capturing those individuals who you're missing. So your patient partners may be those folks who are the super activated and engaged patients, but if you have perhaps an advisory organization or another constituency group that represents some of those harder to reach patients and have their representation on the advisory panel, that sort of helps to capture all of that without necessarily having them involved and available.
And often they use the caregiver for the,
Yes,
for the patient.
absolutely.
That kind of provides the voice of the experience for the patient. So I've seen that many times.
What other questions are there? Are there any other challenges that are not listed or that we haven't talked about? I'm sure there are many. Yeah, in the back.
I was just going to say, I think there's a tension between building trust with diverse communities, but also putting them into boxes in terms of patient versus stakeholder versus, clinician versus researcher. I think people naturally wear a lot of hats, as a metaphor, and also kind of a tension between saying the asthma community and the diabetes community when we live in communities with all of that happening at the same time. So that's a tension I've experienced in my project.
Thank you. Thank you for sharing. Okay, Danielle, pass me a notepad. No, that's hers. Sorry.
So only one. Oh, thank you again for a wonderful presentation. One thing I'd love to just kind of maybe bring out there to the group is on there's nothing about resilience. And so we usually come at it at disparities or talking about barriers or talking about engagement and looking at that piece of how can we address those things. But I think that one thing that we see a lot in our community is that there's not a real focus on what's being done that's being done well, and highlighting that as being a success. And I think if we maybe came at it with more of a look at all the things that this community is doing right, doing well, succeeding at, I think potentially we'd have more individuals who'd be willing to participate who wouldn't be feeling that they're coming at a, that they're being potentially looked down upon because of what they don't have or because of the barriers that they're experiencing.
Okay. So celebrating. Thank you for that.
Let's get back to a conversation I had with Danielle when we were walking out this morning. And that is that I think that one of the things that happens with engagement is that people think that they can learn it overnight. And when it comes to biostatistics, nobody says, well, we don't really need a statistician. We can figure out how to do the analysis when we get there. Nobody says, oh, it's really it's kind of a problem to recruit people, so let's not have a recruitment nurse. Let's just put up signs and hope that patients show up to our clinical trials. But there's something about engagement that there's not the legitimacy and there's not the requirement of demonstrating that you have the capacity and that you've appropriately budgeted for it up front that there would be for any other aspect of science. And I think until we get there, we're going to continue to kind of hobble along and do it half-heartedly. And I always draw the parallel to, if you're doing a hypertension study, you have to use the same blood pressure cuff. You have to know that it's valid and reliable. But if you want to do engagement, you can kind of do anything you want, and all you have to do is say that we'll do it, but you don't have to demonstrate that you know how to take blood pressure.
And so I want to pick up on this thread too. I'm still mic'd, so I don't need a mic, right? Oh, was there another question? No, you go ahead. Okay, so it picks up on this part of, when you talked about resources that are being developed for researchers, it's very programmatic, how to budget, how to how to write an engagement. But there is a change in the type of skill set that you need, and we heard this from the interviews, that traditional research, quantitative, is not, you don't learn softer skills about how to build relationships or how to do team science. And I'm curious, when we think about tools and trainings for patients, we talk about making them more equipped to come to our tables, but how do we support, or what efforts are underway to tell researchers you need new skills, and this is how you get there so that you're better at team management and that give and take and those things that you talked about being good, about thinking differently, about leading from within, those sorts of things. Are there efforts underway to address
Yes,
that?
there actually is a team science effort that is underway, that's currently under development. And part of what we're doing is we're sort of looking at some of the researchers in our projects that are leading more of the stellar projects, quote unquote, if you will. And we're hoping to sort of take a profile of those researchers to pull out and tease out what are some of those characteristic traits that they have in terms of the leading from within, in terms of, I don't want to use the word passion, but what are the unique qualities that comes from a PCORI researcher, if you will, and taking some of that and weaving that into the team science training that we develop. We have heard from our patient partners as well that researchers have a very difficult time communicating with them the findings of their research. Something that's just sort of as simple as a basic conversation, give me the nuts and bolts, they found that researchers sort of really struggle through that. So, and that's another piece that we're hoping to weave into the team science initiative that we develop. So.
Yeah, I was just going to build on that comment with another question about, PCORI is a relatively new term, but community-based participatory research came before that, and before that, participatory action research, and it's an evolving concept. And so I just wondered, in terms of the tools and things, if you were looking for people with expertise on that study, section, or on the proposal, would you look to their CBPR skills or other things like that when evaluating a PCORI application?
We don't necessarily look to their CBPR skills per se, if you will, but we are looking to the field of CBPR in general to really sort of help to shape and inform some of the things that we're doing in PCORI in terms of the core concepts and principles. So there's a lot to learn from that field, as well as other public health, in my opinion, in general. The whole concept of engagement is not new. It's new in this space. It's new to this sort of cohort of researchers, but there's a lot of great information that exists out there that we're able to sort of leverage and pull together. Thanks for that point.
Any other questions or comments? I want to close with one question and then we'll go to break, and that's, we heard this in the video that you showed about when I was approached for research in the past, it was that I was the person that was being helped through research. I was the participant in research. And I brought that up, and one of the things that we heard is that we have this new ask where we flip the switch and broadly, okay, patients, we want you to engage in research, but that means something different. Is there anything that PCORI is doing to support just changing the conversation about research? And so I'd love to hear your answer. And then Nancy, I'd love to hear your thoughts too about how, because you're going to be our next speaker talking about changing the face of research and making patients part of the teams, how maybe you have seen some really successful ways of changing the conversation about partnership in research.
So I can say we've run up against this issue as well a number of times with our PIs in terms of when they're approaching engagement of patients, they don't make that distinction, if you will, of how to retain and engage patients as participants in the study versus as patient partners in the study. So that's something that I think that we at PCORI need to do a little bit more work on in terms of really delineating that and making the distinction between the two to really sort of help and support our PIs in understanding that just by doing engagement or introducing an engagement initiative to retain study participants is not necessarily what we're looking for in terms of engagement. And we've come up across that issue a number of times.
My experience is that the key thing is that the funder requires participation. And if the funder doesn't require participation, you won't have any participation. I mean, that's it. And it doesn't even have to be funded. It just has to be required. The other thing is whether or not the researchers find the input valuable. I've seen researchers have one bad experience with a patient, and after that, they're like, well, I'm never doing that again, you know. Well, did it kill you? Is there lasting damage? But patients frighten researchers as much as researchers frighten patients in that environment. It's very intimidating for everyone. But I do think that unless the funder requires it, not going to happen.
Shannon?
Are there any studies done about measuring the impact of patient engagement? How do you measure that? How do you measure?
These are all ongoing conversations that we're having at PCORI. Actually, we're in a very unique position in that we're able to essentially sort of do an experiment on ourselves, if you will. Now we're at a place where we're gathering a lot of evidence from studies that we funded, and now we're in a place where we can start to look at that and assess what is the impact that engagement has on the conduct of research. Right now, we're sort of capturing that, but it's more self-report. It's researchers who are reporting in their engagement reports what impact they think that patients have had on their study and the conduct of research. And then we sometimes go and do follow-up key interviews with patients as well. But again, these are patients that the PI has identified. So we're still sort of navigating and figuring out how to best address that.